you all this wonderful discussion on phacoemulsification in difficult situations. As we all know that phacoemulsification is highly effective surgical procedure for treating cataract and improving the visual acuities. But there are certain conditions and certain challenges that each surgeon faces. So tonight we'll explore all those strategies and all those techniques which can be applied to perform those successful phacoemulsification in those challenging cases. As we delve into the topic of phacoemulsification in difficult situation, I'd like to encourage each and every one of you to participate actively in this session, and please feel free to share your thoughts and experiences and questions in the comment section. Before we start this daredevil innings, I'll request Dr. Ravi to kindly introduce our worthy speaker. Thank you.
Thank you, Dr. Srishti. So this is a topic which will be dealt with by Dr. S.K Narang, sir. And he needs actually very little introduction. So this is about his hospital. There's a small video where that's his institute that he has founded himself, which is located in North Delhi. He started this institute in 1993. Has all the facilities of contour LASIK, ICL, advanced cataract surgery, and also VR surgery. So he is the founder and chairman of this wonderful institute, which he started in 1993. And he's also the medical director and the chief surgeon at Narang Eye Institute. And he has catered to over 1 million happy patients over the last 30 years. He's a very versatile surgeon and he is an all-in-one surgeon. He does anterior and posterior surgeries, including your LASIK, your cataract, ICL, retina. And after seeing so many patients, also he has time to set up a YouTube channel which has over 1,000 subscribers and 55 videos. I always am a firm believer that the eyes which are behind the microscope are always more important than the eyes which are in front of the microscope. So keeping that phrase in mind, one, I would like Dr. Arun to say, Dr. Arun sir to say a few words about our guest speaker here. And after that, we'll move ahead with the presentation. Dr. Arun sir.
I think Arun sir has not been able to join yet as of now.
He's there.
Sir, you have? Okay,
Yeah.
okay, great.
There, Ganesh.
Please.
Hey. Yeah, I can't see, sir. Abhi sir dikhe mere ko. Sir, good evening. Good evening, sir. Good evening. Sir, so very, very, very happy to see sir coming and will share with you few experiences, etc. But I would request everybody, I was very delighted, Ganesh, by the way, to see Shrishti and Ravi taking the lead to be the moderators. So they are our fellows, and seeing them to moderate, I mean, it's a big opportunity as well as responsibility. Having said that, I would request Ganesh, ऐसा कोई outing करो जब सब fellows 2-3 दिन के लिए सर के यहाँ पे जाएं. I mean, you have to see it to believe it, how he works. Morning 8 o'clock in the OT, evening 8 o'clock at home. For so many continuous years, this is something what a fellow has to see. पढ़ाई अलग चीज है, skills अलग चीज है. And to see him work, that dedication, the passion, the smile with he meets everybody. मैं इतनी बार मिला हूँ सर से, and I always tell him, and I'll tell you all today, I'm yet to see a person meeting whom I get inspired more. Yet to see. And you have not seen the hard times he has had and the way he has fought and the way as a human being, I think, most respected person I would see. So
thank you so much.
बाकी तो सब सर बता देंगे, कुछ मुझे तो कुछ आता नहीं है, but yes, the person to go and meet, and I think I actually few days back I got a call from Sebin that he wanted to go and meet sir and be there in his OT and spend some time with him. And when he came back, sir, I'll forward you his message. He said, amazing, this was stupendous, this was something I'd never dreamt of. So many surgeries, so many LASIK cases. And sir, luckily, उसके लिए unlucky है, लेकिन वो lucky भी था कि he has seen one patient in Nepal and he was being operated.
He was there that day.
For contour LASIK.
They both of them met, surprised.
Yes, sir. Yes, sir. So he has a big name in Delhi. I think the biggest practice. I don't say others have different kind of practices, but I have seen him as a most ethical practice. One of the roaring surgeons with everybody, every company, every ophthalmologist vouches for. And with this, all yours, sir. Please teach the difficult cases. Please teach the and बीच में sir आप थोड़ा lifestyle भी, life dedication भी वो सिखाओ वो that will be more helpful for the fellows.
Yes, we can. So, thank you so much for very kind words. Very presentation.
Yes, sir. I think we can share your presentation, sir.
Yeah.
And the stage is all yours.
So, can you see my presentation now?
Yes, sir. It's clear and you're audible, sir.
So, yeah. So my presentation, first of all, Dr. Arun has spoken very kind words for me. I'm not, it sounds like I'm a great person, but I'm not. I'm an ordinary, an average surgeon. I call myself an average surgeon. I have seen better surgeons than me. Only thing is that again, old thing, the experience counts. Maybe the experience has made me a little more successful than the others. That's all. Dr. Arun has been telling my timings of working. For the last 2 days, I am starting my surgery at 7 o'clock in the morning. And am I audible, Dr. Ganesh?
Yes, sir, you're audible, sir.
Yeah.
So yesterday and today, I've been starting my surgery at 7 o'clock because of the big crowd and the OT. And then doing my LASIK. Saturday evenings, I don't work. So I thought I'll share. I have a good evening, very nice evening with all the people. And I'm sure the audience has a lot of younger people because the expert audience, they don't need to see my presentation. So I have divided my presentations according to the, in 2 parts. That is, first part is for the beginners. And there are few parts in the later part also, which beginners can benefit from it. So let's start with because the most important part of the phaco is the rhexis, of course. Once the rhexis is good, half the job is done. Your rhexis good, surgery is almost done. Then after that, it's just the matter of doing it again for years and years, and you never go wrong, almost never go wrong. Not that you can't go wrong. So, इसको जरा फॉरवर्ड करिए, क्या हो गया, आगे फॉरवर्ड, अच्छा इसको क्लिक करो, नहीं बना, I'm sorry, there was some glitch. So lots of types of Capsulorhexis. Previously we used to do can opener, envelope technique, but now the CCC, that is continuous curvilinear Capsulorhexis, is the in thing. It has to be that. So we'll talk about only continuous curvilinear capsulotomy. We'll not talk about the other types of capsulotomies. Anybody can stop me in between and ask questions when we start with the videos. So capsulotomy, Capsulorhexis is when you tear the capsule and move around on the anterior capsular surface, anterior capsule, and complete the rhexis from inside out. So the good Capsulorhexis meets the demands of very advanced cataracts also. IOL implantation surgery is very important for the IOL to remain centered, reasonably centered, even after the maybe little decentered rhexis. Can be reproduced by experienced surgeons n number of times. So a normal busy surgeon does it about 20-30 times a day. And there are potentials of changing sometimes according to the circumstances of the eye, according to the conditions of the eye. So first thing, due to the lens capsule shearing property, which resembles a cellophane, like shearing, everybody knows what shearing is. like when you raise a flap and then move around in the circle. So this is called shearing. It doesn't, shearing has advantages because it doesn't give radial tears. Hydrodissection is very easy. After that, without any risk, I will say, not say easy, but it has to be proper hydrodissection, but it is without any risk of extending the capsular margin to the posterior capsule. Zonular stress is very minimal, even in advanced cases of pseudo exfoliation. Zonular stress is reduced, so you have reasonably secured capsular bag after the, and the turbulence is contained if somebody's, most of us are doing most of the capsular nuclear fragmentation in the bag or maybe on the anterior, near the anterior capsule. So turbulence is mostly confined to the capsular bag instead of in the anterior chamber. So for facilitates cortical aspiration, as we all know, beginners, these tips are good for the beginners. And IOL centration I've already talked. And with PCR, if there is an intact anterior capsule, you can always put a IOL in the sulcus and capture it. And minimal PCO formation is there. If suppose that the 9th point is that if there is a PCR, if you have entire Capsulorhexis, reasonably sized Capsulorhexis, you can always put the 3-piece lens in the sulcus and capture the optics so that the refractive error is also not very much disturbed. Now, prerequisites, high microscope magnification, that's not necessary. That's getting used to it. Good microscope, of course, is an asset. Illumination should be good. Capsular pupillary dilatation should be good. Maximum which can be achieved. Although we'll see a few cases where there is not enough mydriasis, still how we deal with them. Depth of anterior chamber should be maintained throughout. I will tell you some tips how to maintain the depth of anterior chamber throughout the Capsulorhexis procedure. Then you should always respect the zonular attachments, because sometimes it happens that zonules are attached very anteriorly, very towards the center of the anterior capsule. So when you're moving around, sometimes these zonules, they don't let you advance with your Capsulorhexis, and you have to, what size you have to determine beforehand. So I always, in my practice, always ask before sitting on the chair, what IOL? What IOL? Because if it's a plate haptic, I prefer a little larger Capsulorhexis. If it's a C loop lens, I prefer about 5 mm rhexis, because I don't want the IOL capture later on. So the 2-3 methods are important, which are popular. First is with the cystitome needle, then with the Utrata forceps. Then we nowadays, not nowadays, for the last 7 years, we have flats with us. So that gives a wonderful Capsulorhexis. And then Zepto is another one of the used to be popular technique. Now I don't know how much popular it is, but Zepto is one of the instruments which can give you good Capsulorhexis. So you can do the Capsulorhexis through the main incision, through the side port incision. I'll demonstrate just now. Irrigation, I don't think it is necessary. Viscoelastic is fine. So rules is, again, the chamber should be maintained. The magnification should be high. If you have a good microscope, you will have good reflex. Your ocular viscous device should be inside the eye, slowly, carefully, initially, and 360 degree. From this is 7 point is very important. Complete the rhexis from outside in rather than inside. And repeat grasping when you're doing with the forceps several times, which means opening by sectors. One sector, stop, wait, then go for the another sector, then stop, wait, see whether your size is okay. Then zonular fibers I've already talked. Small rhexis is very easy to perform, but it becomes the phacoemulsification becomes difficult. But small rhexis can be widened later on. I'll show you just now how. So irregular rhexis is better than one with a tendency to escape. So it doesn't matter if there is some ear dog, it is rhexis is hardship, but till it is continuous, it's fine. You have to you can go ahead with your phacoemulsification safely. If problem appears for the beginner, especially, they should convert. There is no ego problem. You should convert them, because the problem complications are worse than the conversion. So now let's see the Capsulorhexis in different situations. Now I am doing, this is not me, I'm doing, this is one of the fellows who is doing it through a side port. So one made, he has made the main port, gone with the viscoelastic through the main port, and then made a side port. There can be two variations. There can be variation in this. You can make only side port, then make the rhexis, and then go to the main port. But what happens when you inject sometimes OVD from the side port only, there are very high risk of having descendant membrane detachment. And I have, frankly telling, I have done this at least 3 to 4 times in my lifetime, doing a DMD from the side port, because side port was not big enough. I injected viscoelastic, and viscoelastic went between the DM, went between the stroma and DM got detached. And worst part is that I did my rhexis on DM and completed the phaco. And next day, but I realized at the end of the surgery that I have done a disaster. And next day, cornea was white. So this is how a beginner should do Capsulorhexis from the side port. Advantages are that you will not lose viscoelastic again and again, and you will be able to complete rhexis in one go. This is a reasonably smaller rhexis because this is done by a fellow. Not that I don't make small rhexis. I make small rhexis sometimes unintentionally, sometimes intentionally also. So the rhexis is complete. I agree it is a smaller rhexis, but this doctor did not inject viscoelastic even once during the Capsulorhexis. This is rhexis again by the side port. Now, again from the main port, you need a lot of control if you want to do the rhexis through the main port. So I make only the main port initially and then make a rhexis. Only thing is that if you put too much pressure on the posterior lip of the wound, it becomes difficult to complete the rhexis in one go from the main port. So see, it's reasonably fast. This is not a fast forwarded video. This is a normal speed video. And this I am doing it and reasonably well sized through the main port without injecting the OVD even once again. But there is no harm in injecting. If you're losing the chamber, if you're losing the OVD, you can inject OVD again and again. Only thing is that when you're doing with the needle, you have to be careful that you don't damage the section with the needle because this needle is very sharp. Sorry, somebody asked something?
No, nothing, sir. Please carry on, sir.
Okay. This is done. Now we come to the rhexis in difficult situations. This is a hypermature cataract, as you can see. I am going through the main port, and then now beginners are always afraid of Argentina flag sign, Argentina capsulotomy. But I tell you, I'm not bragging. We did not have it in the last 5 years, although we operate so many hypermature cataracts. Not that we have become very expert in this Capsulorhexis. We are still as bad as or as good as anybody who is less experienced or more experienced. But I tell you one tip to avoid Argentina flap, which I tell everybody, that when you enter the central, you make a central puncture, don't wait for central puncture to happen. Just rotate the needle slightly as soon as you enter the capsule, so that the capsule has already one circular part. Once there is a circular part, it will not extend in the periphery. That's a promise. You can see it, you can do it, and you will never have Argentina flag in next few years to come. It's the most dreaded thing in hypermature cataracts. Now again, this is done. Now this is rhexis in intumescent cataract. So again, the staining should be good. If you are not satisfied with staining once, stain it second time before injecting the OVD. You see, I have just rotated it. After puncturing, just rotated. So I did not give time for capsule to extend in the periphery. And it's a very small rhexis. So I'm losing now. I have taken a forceps in my hand. I want to do with the forceps now because it is trying to extend. So you have to always keep a utrata ready when you are doing Capsulorhexis in an intumescent cataract. And this rhexis is reasonably small, but I can manage through this rhexis my phacoemulsification. But let's go to the next slide, next presentation. And now this is another intumescent cataract. This is again, same. Yeah, see, I've rotated. We'll go to the next one. Now this is a rhexis done through a this is same case where I've done phacoemulsification through a smaller rhexis. Lens is already gone inside the bag. Now, how to extend it? I've gone with the vanas inside, cut the Capsulorhexis margin, take the utrata forceps, and in a controlled way, rotate it. Stop, catch it again, stop, catch it again, stop, catch it again. And now this, see, I've done it in all quadrants, as I mentioned earlier during the Capsulorhexis. And see how beautiful. It doesn't look like it was a hypermature cataract when the Capsulorhexis was small. Now this is again a very good presentation for the beginners. This is done by my experienced surgeon, but she has demonstrated it very well. So again, staining. She has gone through the main port. She'll make the side port. She has gone through the main port. You saw I went through the side port. I started from upside. She started from inferior part. And now she's taken the forceps. This is a very important video. Small, very small, just about 2 millimeter rhexis. Now she will extend it with the vanas. She has given a, now first, this is very important. I'll just pause it here. After making a small rhexis, she has gone inside. This I learned from her only. She has gone with a phaco probe and done some suction of cortical matter, which was there, which was not a liquid cortical matter. It was a formed cortical matter, but she sucked that cortical matter with the help of phaco probe. If I would have done it, I would have sucked it with the help of a cannula and syringe. And after doing this, she went inside with the cabana scissors. She has given a radial cut. I would have given a curvilinear cut. Now I'll see. Okay, sorry. See, she has given a radial cut. I will prefer it to be a curvilinear cut at margin, but she has done it very well. This is a very good tip for the beginners who are afraid of doing rhexis in Argentina because of the fear of Argentina flag. There will never be an Argentina flag in your cases. See, and a reasonably good rhexis size. Now rhexis in a scarred capsule. And I will tell you, I failed in this. This was a very, very scarred capsule. I'm trying my best to avoid the scar tissue, but no, capsule is scarred. So I'm trying to puncture it. So I made a small dent in the capsule and now taken the forceps. It's not catching. Another neck. Nothing happens, sorry. And I had to convert it. See, whole capsule is fibrosed. So upside on the upper part, the curvilinear axis is there, but in the lower part, it has extended in the periphery. So here, I thought it was best to convert it because my concern was to give the vision to the patient. So I just cut it with
Ravi?
Narang sir, are you there? I think we may have lost his connection. I think electricity must have gone there because that's what the inverter was beeping. Meanwhile, any questions from the audience before we reconnect with sir?
I think if Dr. Mayank and Dr. Arun sir are there, I feel.
I think he is back now.
Yeah.
Narang
Yeah.
sir,
Narang sir? Yeah,
unmute
please.
yes, unmute कर लीजिए sir.
Unmute yourself. No.
fibrous capsule.
Yeah, sir.
No. Yeah. So done.
Hello.
Yeah. Just we are getting it connected, reconnected again. So all in one situation.
Hello. Sir, excuse me.
Yeah.
Sir, मैं बात कर रहा हूँ. वो अरुण सर अभी कॉल पर हैं.
अच्छा.
Okay.
सर मैं आ गया इधर. सॉरी, मैं इधर से बोल रहा हूँ. मैं किसी से मिलने आ गया था सर. सॉरी.
No problem.
Right. Anyways, sir, Narang sir, you can reshare your presentation. Yeah.
Please share. Just a minute. Just a moment. Give me a moment, please. Here connected.
Yeah.
So all things in one situation. So I have made a small curvilinear movement with as soon as I entered the capsule, and because the liquid cortex is coming out and it is obscuring my view, so I have done a suction with the help of cannula. See, I'm sucking the liquid cortex, so it decompresses the capsule, and now I've gone with the needle again, but still it is trying to go out. Now I've taken a forceps in my hand. It is still trying to go out. The rex is trying to go out, but somehow I am able to solve it somehow. Am I audible, Dr. Ganesh?
Yes, sir, you're audible, sir.
Okay. So I have done now completed. I was able to salvage. I was able to bring the Capsulorhexis back in. So that's why this slide is called all in one, where I had used needle, forceps, and then see, I have now extended the Capsulorhexis before putting in the lens, although it is very risky method. But it is better to put in the IOL first and then extend the rhexis. Here I have done extension of rhexis before putting in the IOL. And then it is same, nothing spectacular in this. So this is all about this presentation. Now we'll go to the next presentation. Any questions from the beginners, from the new fellows about this presentation?
So I had a question, sir. So like in intermittent cataracts, when we're expecting that there is a, like there is a positive pressure or very high intralenticular pressure, like you showed that one mini rhexis can be made. Is there any role of maybe I go in generally with a straight 26 gauge needle and just puncture in straight and aspirate whatever comes out? And that also kind of prevents Argentinian. Any thoughts on that versus a mini rhexis?
Yeah. See, I think mini rhexis is better in the why? Because when you are going with the straight 26 gauge needle, it has sharp edges. So there are good chances. There are not good chances. See, it's all depends on how good the surgeon is or how experienced the surgeon is. But it has more chances of extending rather than doing a mini rhexis because the edges of the needle, the needle bevel, they are sharp. But here, when the needle is bent, you just go in and just give a small rotatory movement, small, and then you can do as cortical aspiration with the help of cannula, or as my fellow was doing with the help of through the small rhexis, through the cortical aspiration, then extend it in the second. And I tell you honestly, I did not have, maybe I'll have it on Monday, but we did not have any Argentina flag in last, say, 4 to 5 years. So I prefer it this way. But if somebody is well conversant with the other method, it's fine. I've seen people doing it. It works.
Okay, that's great, sir. Thank you.
Shall we move to the next presentation?
And also one question from the audience was, I think, what is the difference between, I think, main port and side port for rhexis? I think that's what they meant.
Somebody is asking the question. I tell you, okay. From the side port for the beginner, or sometimes when the chamber is very shallow, like in high hypermetrop patients, if you do it from the main port, it will. You have to inject OVD again and again. The chamber, you will keep on losing chamber because there is a positive pressure in high hypermetropes. And sometimes in intumescent cataracts also when the chamber depth is just about 1.5 mm. In those cases, even now, I do side port rhexis because you don't have to inject OVD again and again. So this side port, I never use it again through the rest of the surgery. So it doesn't have much impact on the surgical outcome. So you can make a side port and do it and then go through but most of the times I prefer to do it through the main port.
Understood, sir.
Yes, sir. I too have a query regarding what is your experience of using high molecular weight viscoelastics in case of mature intumescent cataracts so that it doesn't run away. That was a nice hack so that we turn the flap so that it doesn't run away. But what if we use high molecular weights for the beginners?
I think it's a good idea. And my fellow who was doing a small rhexis, she was doing it under the high molecular OVD. But I normally don't use high molecular OVD because I feel that with my volume, it hampers my speed, because the shearing becomes very slow. So that's just a matter of preference, but I think high molecular OVD is better in these cases for the beginners.
Thank you, sir.
So we go to the different types of scenarios now, not necessarily phacoemulsification, other scenarios. So this is a very forgotten technique, 4-quadrant technique. I think all fellows should know this technique because this technique, I use it sometimes even now. In special situations, you must have all seen beginners, fellows, we always get we give softer cataracts so that there's not much of struggle. But sometimes the experienced people can also struggle with the soft cataracts. This 4-quadrant technique works very well. So I'll show you how I do. This is just for this talk. I recorded this. My doctor told me to record this just for the sake of showing it that it still exists and it can still be useful. So this is slightly fast forwarded, or no fast forward. This is normal speed. This is me doing 3 days back just for the sake of this presentation. So 1, 2 second, just 90 degrees at the first, then third at 90 degrees of the second, then fourth trench. And here, note again, I've gone to the first again. Then I have tried to split, because first when I did initially, it was not deep enough. Normally you should not make it deep enough, and see how this is normal speed, or maybe 1.5 times speed. Yeah, maybe 1.5 times speed. It's so easy. Softer cataracts has become so easy if you do 4 quadrant, because soft cataracts, they don't have any technique. Jo bhi kaam kare, wohi kar lijiye. And this works very well. I think from the beginners, they should know the soft cataracts of this 4 quadrant. They should try to do it. This is then the rest routine. So what is the fundamental of this 4 quadrant? Go first trench, second trench, third trench, fourth trench, then again go to the first trench, and again go to the second trench. Look into the middle. There can be some plaque which is thicker. Do it, slight sculpting there, and split. It becomes very easy. Don't do 1, 2, 3, 4 and start splitting. 1, 2, 3, 4, 1, 2 again. Right? I'm clear about it? Okay. We'll go to the next one. Next. Now, this is the stop and chop. This is my most preferred technique. For up to grade 3 cataract, I do this always. Up to grade 3. So grade 2 and 3, I do this. This is a very safe technique. It is safe for beginners, for experienced, everything. For beginners also, it is very safe. And look at this, my movement. I don't, after Capsulorhexis, I don't rotate normally. I just straight away after hydrodissection, I don't rotate. I go straight away inside because I'm sure about my hydrodissection. I've seen a fluid wave. And I have moved, if you have noticed it clearly, that I have moved my nucleus anti-clockwise. Because clockwise and anti-clockwise, if there are some adhesions left, they will break easily. And it is always, when in the dialer is in your left hand, it is always easier to rotate anti-clockwise than clockwise. And first trench, second trench, again go to the first trench and then try to crack. See, it cracks so easily. But you should be deep enough, about 70% depth, 70 to 80% depth. That's a personal preference actually. And then divide into, then each half into 2. This is a very standard 4 quadrant stop and chop technique. Inject viscoelastic substance in between to save the cornea. This technique can sometimes work up to grade 4 cataract, but I think it's safer to do for first and 2 and 3. For first, there is no technique. Whatever works best in your hand, but still 4 quadrant technique one must know. And so I think this is clear. Next is, now this is a flower petal technique for hard cataracts. I do it very often. This is a very hard cataract, say about 6+ cataract. Anything above 5, I call it 6, although the regular grading is 6.9. People call it 6.9. So first trench, then 90 degree, then small chops, see. Again, anti-clockwise, sometimes I go because it is easier to rotate anti-clockwise. Always I prefer it. And multiple chops. जैसे हिंदी में कहते हैं ना, see, now I have taken out the endonucleus. We'll go back a little and people should notice. And after a point, the endonucleus comes out. There, I'm going back again. Multiple chops. And at one point, this central part comes in the probe. Now, what we are left with is a very hard epinucleus, which is very hard, but everything is happening inside the capsular bag. So hardly there is any corneal compromise in this. But yes, I keep on injecting viscoelastic again and again. And then you can take each quadrant and see, I'm again dissecting it. I am taking with the help of second instrument. Now, first was chopper. Now I've taken dialer. Again, I'm doing dissection in situ. This is called dissection in situ, where I'm still leaving another layer of epinucleus outside to save my posterior capsule, because I know there is no cortical matter behind the nucleus to prevent anterior posterior capsule from coming inside the probe. And ultimately, we are left with this small plate, which again I'm injecting methyl cellulose. Now here we are presenting one paper in ESCRS this time, ESCRS coming in October. We are presenting a hybrid phaco. Now what is hybrid phaco? This is a 20 gauge needle I'm using. See, epinucleus, and after epinucleus there is nothing. So this is a 20 gauge needle I'm using, but in very hard cataracts like this, I use 20 gauge needle for chopping. So after chopping, after chops are done, it takes very little time if you have a bigger needle because of the higher grip with the needle, with the 19 gauge phaco needle. So after this 19 gauge phaco needle, after the chopping is done, the endonucleus is done, then you can switch to 20 gauge needle and then do it very safely, because 20 is safer when you're working near the posterior capsule. Now these were few situations where the Capsulorhexis situations, soft cataracts, stop and chop, and then very hard cataract. Now we frequently face these problems of small pupils. So now I'll show a video of a small pupil. This is a small pupil. This patient has some posterior synechiae. See, we have multiple options of doing small pupil. We have hooks, we have rings, and this is one of the methods where you're in a great hurry. I'm sorry I'm saying that. Surgeons should never be in a hurry, but this technique works very well. So first thing is, when the pupil is small, stain it beforehand and go, and with the dye, go under the pupil so as the periphery of the nucleus is also stained. Because once the pupil is enlarged, then it will be difficult. Now see, I'm stretching with the dialer, but still I feel the pupil size is not enough to do the phacoemulsification. Now I'm going with two instruments. One is button shaped dialer and one is Y dialer. So I'm stretching. Of course, it breaks the sphincter, but this patient doesn't have a sphincter, already working sphincter, because this has a lot of posterior synechiae. Now I feel, for my comfort, this much Capsulorhexis is enough for me to proceed with the. Here, the high molecular weight OVD work is very important in these cases. Although I have not used in this case, so I've used needle as well. This is very hard cataract, very hard cataract. As you can see from the color of this nucleus. See, now the rhexis is complete. I have tried to make as big as rhexis as possible. Now I've gone it with and the phaco is being completed. Whole nucleus, I was not able to chop, but when the whole nucleus got flipped, I'm chopping it almost at the posterior part of anterior chamber. पहले पीछे वाला ले लिया, खिसक ना जाए, नीचे ना चला जाए. So that's ऊपर वाला तो रहेगा ऊपर, it will stay up in the chamber. So नीचे वाला पहले निकाल लिया. I've taken the other part and now the anterior part. Again, see, I have not come out. I've stayed in, asked my assistant to switch off my irrigation and OVD from the side port. My probe is always in. I don't want to lose the chamber, so that if there is any posterior capsular problem, it will not stretch, it will not extend, and the phaco is complete. Then the lens implantation, that's routine. And then I will suggest, I don't know whether I've done this in case or not, I will suggest that before doing IA for the viscoelastic, we should give 2 radial cuts, because we can't extend this rexis. I showed in the previous 2 radial cuts opposite to each other at 3.9 or whatever, so that the pupil doesn't get phimosed, rexis margin doesn't get phimosed later on. Now we'll see another case. Just a minute. It's buffering. Just a minute, moment.
I think, sir, it's not responding, sir. So you'll have to close the PPT and restart.
Yeah.
So your experience of using pupil expanders, which are available nowadays.
Yeah, I'll show just now. And then my further this thing. This was the manual stretching, and next again. Now another scenario we have. No, this is not. This is the same one. उसके आगे चलिए. ये तो वही होगा ना, उसके आगे चलिए. Now, sometimes what happens that you have small pupil, but you have a pupillary membrane. I'll show how to do this. See, this is again a small pupil. I've done the staining. And now look at the magic of peeling the membrane. First, I have done some sweeping with just a dialer. So as if there is any adhesion between the posterior surface of the iris and the lens, that is broken. Now I've gone to the pupillary margin and see how I'm peeling the membrane. And as I'm peeling the membrane, the pupil is getting bigger. So no stretching devices, and pupil is good enough for me to proceed with the membrane. यहाँ पर ये वाला
नहीं, I think slide number 11 है. No?
इस पे जाना है. Yeah. So I've done this membrane peeling, and the pupil is now big enough for me to proceed with the. So this is a very, very important thing. You can just get away with only peeling of membrane and not using any pupil stretchers or pupil marginal rings and hooks. You don't have to use them. So I'm doing stop and chop just to be safe, because a small rexis, small pupil, I don't want to catch my pupillary margin with the probe. Just is routine, then that it is routine. Only thing is that you have to be slowly going to the smaller pupils. पहले dilated pupil में phaco करिए, then mid dilated में करिए, then come to these sizes. These are not mid dilated also. The previous one was not even mid dilated. It was actually rather a 3 mm rexis. But with experience, you can do through the 3 mm rexis also. So pupillary membrane peeling is so important. I have not used any device. Then it is routine. Now, as I was mentioning, doing Rexis, doing phaco through a small pupil. This is hardly a 3 millimeter pupil, not even 3, I think. What do you say? How much it is, this dilatation?
Yeah, sir, about 3.3, sir,
Yeah,
3.5.
And see, I'm after doing Rexis, I'm confirming all around with the dialer. I'm lifting the iris so that I know that where my Capsulorhexis has extended in the periphery. I can afford to do, I can do it through the smaller Rexis, but can't afford that it should run away. And I do not know where it has run away. And now it is easy. But again, you have to see that you don't catch the pupillary margin. And it is possible to complete it. See, through such a small Rexis, it is possible. Again, I'm injecting methyl cellulose. Then now with the IA, I'm lifting each quadrant of iris to take out the cortex behind it. And the result is good. Now I'm using telescope for placement of the toric IOL. This was a toric IOL. I didn't know this was toric IOL. So anyway, this is a telescope demonstration also. So I'm checking the Myers on the lens by retracting the pupillary margin. So done. So we'll go to the next now. See what I'm going
so like you had mentioned.
Yeah.
Sorry, sir. Like you mentioned, like we should not catch the Rexis margin while doing like a small
Not
Rexis.
Rexis margin.
What
I
pupil?
mean pupillary margin. If once you catch it, then it will keep on coming again and again.
Okay,
So
my question is, my question is, suppose we catch the Rexis margin, because problem is you're making a very small Rexis. So phaco sometimes. So if we catch the anti-Rexis margin, should we phaco it? Because that time it will just cut this thing, or what do we do?
Yes, we should phaco it. And you will see in the end of the surgery that there's a small extension like a dog ear.
Like a bite on it.
It doesn't extend. Normally it doesn't extend.
Okay.
Right. So what I'm going to show in the video is not an eye ring. It's no financial interests, but it is a Gupta ring. Dr. S.C. Gupta is our senior. He made this ring very cheap and a very, very good ring, very easy to place. Again, staining before injecting any OVD, that's very important. Go under the pupil to see, I'm going under the pupil to stain the peripheries also. And then loading of the ring, then injection of the ring. See, very, very, this is very nice demonstration. I have not gone in with the ring before engaging the 6 o'clock Meyer, before engaging 6 o'clock ring. So, because once you go in, then it is very difficult to retract the 6 o'clock wala loop. So it is better you first go partially in, engage the 6 o'clock wala loop first, and then go with the rest of the ring. And you should have a second instrument, and which should not be a dialer. Mind you, it should not be a dialer. It should be a repositor, which can press it. Otherwise, every time you take out your dialer, this loop will disengage. So you should have a flat instrument in the other hand, and a normal and dialer to engage the ring, and flat instrument to depress that part of the loop to engage it. Otherwise, it will get dislodged again and again. and it will be very difficult. And 6 o'clock loop has to be engaged before the ring is inserted inside. This is a very important tip. We have done it. We have learned it by doing it again and again, that we have done the full ring inside, but then it is difficult to catch hold of that ring, because if you go with the dialer, that loop, if you go in with the dialer, it damages the iris at the periphery, and sometimes there's a bleeding. So it's better to engage 6 o'clock thing before you enter inside, fully inside. So this is a very hard cataract, as you can see, and I'm doing my same flower petal technique with this multiple chops. And same endonucleus I've taken out, as in the previous case I showed. Now again, I'm not taking out my phaco probe. I've asked my assistant to stop the irrigation and then again injected viscoelastic through the side port. So that every time you go inside, you have some chance of disengaging the loops. So this prevents the disengaging of loops. So now, any questions in this?
Sir, is it difficult to remove the ring, sir?
No,
And
it's
how?
very easy. Just engage the 12 o'clock loop, hold it with the McPherson forceps and pull it out. It will come out. Very easy. It will deform, of course, when he's coming. I don't know whether this is there in this. Let me see whether I have it at the end, how I'm removing this. Probably it has been edited out. Otherwise, it is very easy to take it out. No, this is not. That has been edited out by the editor. Otherwise, it's very easy to disengage the 12 o'clock loop, or maybe another one more loop also, and then go with the McPherson, hold it, and it molds out of the section very easily. You don't have to extend it. Now,
And sir, this is easier than the iris hooks, or
no,
this?
iris hooks is, see, there are two separate indications for iris hooks. Unfortunately, I had iris hooks video with me. It's not there today. I'm not showing it because I'm not able to locate it till 7:30. I tried to locate it where it is. But am I audible?
Yeah. Yes, sir.
Yes, sir, audible, sir, but I think presentation.
What happens? Yeah, presentation. What happens that if your pupil is stiff, then it is better to use the rings. If your pupil is flaccid, like it happens in Urimax cases, then it is better to use the iris hooks. And if you, in the middle of the surgery, you feel you have not used any hook, you have not used any ring, but in the middle of the surgery, you have done Rexis, you have started phaco, but now you are stuck. You don't know what to do. The pupil is constricting, it is floppy. That time, it is better to use capsular hooks rather than iris hooks. So first thing is ring, before Rexis, capsular iris hooks, after Rexis, capsular hooks. Am I clear?
Yes, sir.
So before Rexis, either ring. You can see the screen or not?
Yes, sir.
Yes, sir.
There's some question from the audience. What's the question? There was some question.
No, sir.
Okay, no problem. So until now, we are clear about everything.
Yes, sir.
So we have covered soft cataracts, we have covered 4 quadrant, we have covered stop and chop, we have covered floral pattern, we have covered ring, we have covered membrane peeling, we have covered
hybrid phaco.
Manual stretching.
Yes, sir.
But unfortunately, I don't have the iris hooks video at the moment, but I show two interesting cases now. Now this is, I think one of the audience will recognize this case. This has been done only yesterday. I'm sure person is watching. So this is a patient, father of one of our doctors. I will not name the place from where he comes. And he had a retinal surgery many years back at Shankar Netralaya and IOL implantation. And last year he came here and doctor did a YAG capsulotomy for this patient. This is the situation which happened 4 or 5 days back. This lens got subluxated. So what I did in this case, because there was no, see, we have already done a side port, infusion, because it's a vitrectomized eye. So we have done an infusion, already put an infusion line so that the eye doesn't collapse. Now I'm making side port 1. We are 7 minutes in this side port 2, just opposite each other. I have not done the caliper marking I should have done. And now I have taken out the loop of in the anterior chamber. Loop, this is a 3-piece lens. The loop has come in the AC. Now we don't have the fear of dislocation, total dislocation. Even if it's a fear, we already have an infusion line. And then I made the main opening, main section. And when I tried to remove this loop broke. But we already have the full lens in the AC. So that loop broke. Now I rotated and tried to take out, but my section was smaller. So I'm increasing the section. This is an old silicone lens. Increasing the section. Oh, both loops are broken. See, both loops are broken. We only left with the optic and taken out. And now I put pilocarpine in this patient. Just to now what I'll stop here. Can I ask what should be done now?
So either go for a iris fixated or a scleral fixated.
That's what I'm going to do. This is a one-eyed patient, mind you. So we'll go back a little. So as this is a small tip about the iris fixated. So I have gone vertical inside and then rotate the capsule in my meridians of side ports. This is done yesterday. This was done yesterday. And now, but you have to keep on putting methyl cellulose again and again because section is big. So we'll keep on losing the chamber. Back, I've gone behind the pupil, and with this just a cannula, I have done the enclavation. Now the other part, I'm confirming. Now the other part again, now on the periphery, again I'm doing enclavation on the other side. Not first attempt, not successful. Second attempt, not successful. Third attempt, probably successful. See, now you can see 2 peaks in the pupil, this and this. So this is surety of enclavation. And then I confirm it also, again, putting the methyl cellulose, I confirm it with the help of a dialer. I'm pressing the dialer to confirm. Mind you, this is a one-eyed patient. So this is the ultimate picture. We are very sure about the enclavation and then the suturing of the wound. That's the routine. Now, this will be my last video, today's last video. This is a patient who operated by me probably many decades back. See the hydrophilic lens. The capsule got totally contracted and now the lens is almost decentered, totally decentered. Patient has configure vision. This thing I made, but see, I have not made horizontal. I have made the incisions are little upper temporal and upper nasal. I'll tell you why. Now I'm trying to take out this whole thing in the anterior chamber, whole complex. This is a capsular complex capsule with the lens. And then with the vitreous forceps, I'm catching off that, I'm catching the loop the haptic and bring it totally into the anterior chamber. Now I'm safe, at least this will not drop. Vein section, I have to make it 5 millimeters because my iris claw length is 5 millimeter. Taken out with the help of 2 forceps. Again, increasing it because it's not coming out. I don't want to cut the lens inside now because my vitreous is exposed. Out. This has come out. But the capsule bag is still there. Fibrous capsular bag is still there. I've taken it out. There is a vitreous. Probably there is a vitreous. This is I think 6 months old video. I'm doing vitrectomy. I've done anterior vitrectomy. Put pilocarpine. Cutting the vitreous from the section. OVD. And then, see, this is important. Because pupil is not constricting with the vitreous forceps, with the end drift forceps, I am mechanically pulling the pupil so as to make it smaller. See, the pupil is smaller. This is mechanical pulling. The pupil could not become, I could not bring it to the normal size with the help of pilocarpine only. Now the same lens, iris claw, but this time the convexity up because I am going to put it in the anterior chamber. This time convexity up. Previously convexity was behind, that means towards the vitreous cavity. Again, go vertically, move it horizontal, and then the enclavation from the ports which I had not made at 3 and 9. See, now this is at 1 and 1 or 2 and 11 or 10. So this first side, one side is enclaved, and now the second side. Second side, I had some difficulty because this was my first anterior segment anterior chamber iris claw. I have always preferred a posterior segment, posterior iris claw. This I had some problem. There was a small iris trauma also at this moment, but we could do it. So that's all for today. Now I'm ready for the questions. I think I spoke for almost about 1 hour. And sorry, I don't have the iris hooks video, which I could not locate in my archives.
So excellent videos. We all actually learned a lot, and I've very rarely seen such variety of cases presented so nicely in 1 hour. And honestly, we actually learned, I got a lot of, we all must have gotten a lot of tips for handling actually simple cases and difficult cases. For us fellows, actually anything new is a difficult situation because we're learning how to, maneuver ourselves through these various situations. So I'd like a few comments from the academic cell on the presentation. Ganesh sir and
yeah. Thank you so much, sir, for a wonderful teaching session for every one of us. Looking at your presentation is always interesting because you always try to innovate on the go. So that is something that I have seen you do. When you come up with a situation, you try to innovate something new always, and never shy of trying new things. That is something also that I see sir doing very often. So it's great to see a variety of cases, difficult situation, the way you have managed small pupil cataract surgery very nicely, giving very important tips when and where to use certain things. So that was very nice, sir. Looking forward to lot many more presentations from you and
Yeah,
guiding
more
us as well as fellows in future as well. Thank you so much, sir.
And fellows and younger surgeons are always welcome to join me in the OT whenever they want. I start my OT every day at 8 o'clock in the morning. Summers, winters, rains, no rains, everything. Always 8 o'clock every day. So all are welcome to come, and anytime anybody can ask any questions. I also learn from my junior doctors, and learning never stops.
Dr. Mayank sir is here. Dr. Mayank, any comments? After that, Dr.
Just want to thank you, sir, a lot for your beautiful presentation. And in this your continuation, I am looking forward to meet you very soon. And,
He is most welcome at my center in Delhi, and welcome to the OT. Yeah, to the institute also. Yeah.
And we too wish you to like visit sometime whenever you feel free to visit us. Give a kind visit of yours to Jodhpur.
Yeah. Jodhpur, only Dr. Arun Singhi and Dr. Lalit have been bluffing me again and again. They call me and then they forget.
We booked the ticket and cancelled it also.
You'll be able to find me here actually. You'll be able to find me here. I'll be there.
Yeah, I'll come. Yeah. I'll definitely. I want to go there. I want to see the working there. Actually, I've heard a lot about your Jodhpur center. In fact, all the centers, I visited 4 or 5 ASG centers in different cities: Mysore, Goa, Amritsar. They're all world-class centers, and such humble people. I can't imagine seeing so many humble people all in one group. How it is possible?
Raghav, Dr. Raghav is here as well.
Hi, Raghav.
Hello, sir. Good evening.
Good evening.
Sir, it was pleasure watching you on video. Ganesh and I had an opportunity to see you operate live so many times in your OT. So I had a different experience, sir, and loved all the videos, sir. What a collection you have, sir, of videos. Amazing, sir.
It can go on for hours and hours, but only thing is time is always a constraint.
So someday we would even like to see your retina surgeries as well, sir.
Yeah. Why not?
It was absolute pleasure, sir. I'll keep coming to your OT, sir. It's always a learning experience, sir, in your OT.
Most welcome.
Dr. Kaushik. Or I think
Kaushik is
Shristi.
Yeah, he's at Delhi only. Yeah.
Thank you, sir, for such a wonderful and amazing presentation. We learned a lot from your presentation and all the tricks and the tidbits you taught us. We're really looking forward to meet you in person. And thank you everyone for joining us and being so engaging in this session. Thank you so much.
Thank you all. Good night and have a nice weekend.
Thank you, sir. Good night.
Thank you, sir. Thank you, everyone.
Thank you so much. Bye, everyone.
Bye.
Thank you, everyone. Thank you, sir.
Bye. Thank you. इसमें आया था